Welcome! We're very thrilled to be putting together another video today about addictions, and we want to make pretty clear we're just riffing, we're exploring, we have no perfect answers, and we want to make a reminder to our audience that we as experts in social work with victims of abuse, or social work with families, or any role in social work, we can become, ideally, experts about patterns. There's certain patterns that we can say people struggle with or go through, but any individual in front of us, they're their own unique story, and we want to be empathetic, respectful, tender. We want to ask a lot of questions and be attuned to the individual in front of us. So today, while we're talking about addictions, I feel delighted to not only have Carleen, my psychology major conversationalist person, but also have Jules. And your last name is generic?
Budau.
Budau.
Yeah.
Okay. And my colleague here, I believe, is an expert on a lot of grassroots patterns, so I'm very pleased that she was able to be with us here today. So I'm going to read a little bit. This is our Encyclopedia of Canadian Social Work, and there's a commentary in here about addiction, and it's page and a half of commentary, but I'm going to just pluck out some bits that kind of can give us a good start. There is no international consensus on the definition of substance abuse, dependence, and addiction. There are challenges in understanding addiction and explaining both the individual and the social factors associated with it. And on the next page, some little bits I'm plucking. We want to come to grips with behavioral or social theories that conceptualize addiction, theories that emphasize the effects of addictive stimuli, theories that attempt to explain why some individuals are more likely to become addicted than others, and environmental and social conditions associated with addictions. And lastly, our definition here talks about the stress and processes of relapse and recovery. This page and a half of description and commentary on addictions concludes with, and I'll read this little chunk, social workers continue to play a vital role in all areas of addiction research, policy, and treatment. Given the stigmatization of individuals who misuse or abuse alcohol and other drugs, advocacy and policy formulations are critical in issues relating to social justice and to access to essential programs and services. So as I reread all this last night and looked at all this pile of books that I have here, I kind of came to the conclusion that no one really knows anything, really. They have some ideas of some patterns. They have some good guesses. They have a few things that they realize don't work that well. And we're all holding our breath.
That's exactly it.
Is that it?
Yeah.
Yeah, and I'll add one more thing. We've talked in one of the videos about Black Lives Matter and Indigenous Lives Matter. And as we all know, some of the advocates and protesters and rallies and comrade people are saying we wish to take money away from the police and hire more social workers and have us either escort police to mental health disturbance issues, or have maybe 2 social workers go. So part of me goes, yay, this is a good idea, right? This is really good. Well, social workers will go there and will help de-escalate situations. We'll be empathetic, we'll be tender, we'll be helpful, we'll be patient. And then other moments when I reflected on this the last couple of weeks when they've been talking, I was like, what? You're gonna, for $15 an hour, part-time, no benefits, you're gonna send in a social worker, perhaps by herself? And some of these situations could be really volatile and explosive. I'm not sure I want to send in my 21-year-old graduate from a college diploma program to work with these same moments. So I'm both sides and elsewhere.
Right.
And then we also know one of the patterns. So here's our moment of pattern. We know one of the patterns is that our funders will often when there's a photo opportunity or a moment, a historic moment where things are front page of the news, they'll send in a bunch of social workers or cops or whatever to look at the problem. They might then do 500 years of research and documentation and meanwhile cut back all the funding.
Right.
Right?
Yeah.
So we've seen that. We talked in one of the videos about the Highway of Tears and Indigenous women and missing and murdered women, and a report about 1970 talking about women and issues in Canada and so on. But nothing really changes.
Right.
Right? So having said all that, maybe you could tell our viewers a little bit about yourself and maybe some of your beliefs and values around patterns and what you've witnessed.
Sure, yeah. But just to speak to that, I just want to say that that's what we do with paramedics, actually. You know, they don't make very much money. We send them into really volatile situations. I think that they do actually make sometimes $15 an hour with a college diploma.
Yeah.
And
Yeah, this is not what we wish for. So in social work, we have 100 years now of social work history and herstory, and we want to every now and then go backwards and go, wait a minute. 100 years ago, Jane Addams was talking about this issue, and here's what she said we really needed. And maybe this little tiny tidbit of that has been implemented and moved forward. But often the way these things work is only in synergy. You can't take one little aspect of a person's life and say, oh, we talked earlier about mental health issues. We'd say, oh, we'll give this person some antidepressants. And it'll be like joy and rainbows and sunshine. Okay, wait, they're still homeless. They still have PTSD. They still have physical health issues. They have a whole bunch of things. So just giving them a pill a day for their antidepressant,
right.
It's not the solution. It's one significant potentially aspect. But we have to look just like Jane Addams 100 years ago said, do all this and it'll help. It's the all, not just the fleck.
Right. And if we're sending social workers into situations, like my thought is that as a frontline mental health worker, I do respond to a lot of situations. Cops often don't show up at all. And I remember once this man passed out in the elevator, and he was drunk, and everyone was really impatient. I was a casual, so I wasn't impatient with him yet. And so I was like, okay, come on, like, let's get up. I sort of talked him out of the building, and everyone's like, oh, just call the cops. Oh, we want to get in the elevator, blah, blah. And people are just frustrated. And, you know, the cops never showed up, actually. So it was good that I did coax him out of the elevator. But then once he was outside,
problem solved.
Where does he go? And then my manager's like, oh, he's just there on the side of the building. And I was like, well, you just told me you wanted him out of the elevator. I don't know, like, if there was, like, transportation we could call, or you could go to like a sobering house that was not run by the police, where there's actual nurses and doctors there, because I think that drunk tanks are extremely problematic function of the police. You know, people die in the drunk tank here in Prince George because they don't give them medical attention. Like, why wouldn't they have medical attention surrounding them in the first place?
So maybe for our viewers, because we're going to assume they may not know the difference between, let's say, a police-run drunk tank, which is basically a room with a bed, correct?
Isn't it just like a regular cell?
Yeah.
It's just, it's a regular cell. They take away your coat. You don't have a pillow or a blanket.
And a detox program. Tell me about that so that our viewers will know, what is this enriched environment that you're wishing for? What would that look like?
Well, and I don't think that people should be forced to go to detox. Well, I don't know. I think that when people are picked up on the street because they're too drunk, that's a medical issue.
Okay.
They shouldn't be supervised by police. They're not medical people. I know there's an incident here last summer. A woman died in the drunk tank here. Our community said that she had a history of brain injuries, and that she was told before that she had another concussion, she might die, and then she did end up dying in the drunk tank here. A detox center is a medical facility. If you're at a point where you just really need to quit drugs in that moment, they give you a bed, they give you medications, often sort of barbiturates to help you with the detox process, medication to help you not have seizures, it's really hard to just quit drugs.
Yeah.
And usually you're there for about 3 days.
Okay. So it's a medically supervised, very customized, nuanced and discerned looking at your context, but also your body and what's
Yes.
going to happen. Because one of the things that I was astonished with, because I was innocent, there's
Yeah.
only so much you can know in social work. You can't really
For sure.
know all things that have ever happened to all
Yeah.
people on the whole planet, right? But when I did that 1 year with AWAC, I came to realize that most of the people I saw there, if they had a drug addiction, they also were messing with alcohol, and they also often had, as you pointed out, they've had a head injury, or they have fetal alcohol syndrome, or they have diabetes, or they have kidney problems, or they have a broken leg, and so they're taking antibiotics. And so they've got a whole bunch of things, concurrent disorders. That's what I found at that place. So the situation of, Jane is drunk and stoned, and she's at a crack shack, and the police come, let's just say, right? So to take her and just drop her off at AWAC was over my skill level of knowing what to do with her. But also if they dropped her off at the hospital, sometimes my own perception at the time, and I've heard this is part of a pattern, is that the hospital may say kind of she's a repeater and she's been here 50 times, and they may make her wait in the lobby for 12 hours, and then she may just leave somewhere in that 12 hours, and or they may give her a bed, but only for a couple hours till she becomes barely functional,
Right.
and then they'll put her in a cab and send her back to AWAC. So it wasn't necessarily best care. Like, we're dreaming for the purpose of what would be the pattern that we would wish to have. And you're saying a detox place is different than a drunk tank. Drunk tank is basically a room. It's not really very helpful.
Yeah,
But
exactly.
this other option could give people, that kind of client I'm describing, we got to get you back on your kidney disease pills, or we need to ponder, is this a moment where maybe we could help you get into a treatment program directly from here, not 12 weeks from now?
Right, yeah.
Because that's another gap in the...
Yeah, and I didn't even think about that with a sobering center. My just thought is that I feel that a mixture of nurses and security guards could do better at protecting the people who were drunk and disturbing the peace, or maybe starting fights, which happens, of course, rather than the police. But that is another good point, like if they're interacting with health professionals, there'll be databases that the other doctors can see. They could have mental health and addictions clinicians there to help them start the treatment, the process to going to treatment. And another interesting thing is that when I was trying to research Prince George city budgets, I came across an article saying that the drunk tank is basically the same 10 people going over and over again.
Mm-hmm.
That doesn't
That's 80% of the visits are the same.
So that's
10
the
people.
pattern. That's the
So,
pattern we want social work students to be alert to. Look, if this guy is being put 10 times a year into the same drunk tank, and then next year 10 times, and next year 10 times, and next year 10 times, A, it's not working. B, we're spending a lot of money on that, having, let's say, 2 cops be picking them up and bringing them there and supervising them and so on. That might cost, I don't know, let's say $1,000 a visit.
And it's still only a Band-Aid solution.
Yeah, it's not even a solution. It's only a solution for the hotel owner who didn't want a passed out guy in his elevator because it's bad for business.
Exactly,
The
right?
other customers are discouraged by that, right? Yeah.
But if there was an opportunity to medically detox, or an opportunity to try naltrexone, even if the sobriety only lasts, and I think people have this, they're a repeat offender, they're coming back over and over and over again. But if they want to have a few days of sobriety, they're not stuck in the cycle of hangover and craving and withdrawal, they can make a few positive life changes in that time.
Yeah. So the social work profession in our code of ethics is supposed to be all about hope and all about maybe this is the time that something will change. We have to, as a profession, this is how we're different perhaps from police or from nurses. That we try to see the person's whole life cycle. We have a video on that where we talk about from the day of conception till the time someone dies of natural or unnatural causes. Social work has an affiliation or affection for that whole journey. And so when someone's in front of you, that's different than, let's say, a nurse. And I know I'm being simplistic, but a nurse might be like, okay, you're here in Emerge. We're going to look at health Emerge issues compared to the other 10 people in the room right now. And I'm not interested in the 500 years of oppression this person may or may not have had. It's like right now his foot is bleeding. We fix the foot, get him out the door, we're done. Right?
Right, totally. And I honestly feel that sometimes the hospital doesn't even go that far.
Okay.
If someone has an addiction or an alcohol problem, they see that as the presenting issue and then won't even treat the things that need help at all, and which then adds to their pile of pain and things not dealt with, which traps them in there. And that's addictive cycle even more, in my opinion.
You just reminded me, I did a research project, I think right after I was at EWAC, about teeth, which at first you kind of go, what's that got to do with anything dental work?
Oh, lots.
Well, what we found, yes, what we found was a lot of I interviewed, I think, 15 women who were around AWAC at that time and talked to them about teeth. It's been one of my things because all my paycheck either goes to cats or teeth. That's kind of my life, or books, right? And I've had the misfortune to have teeth that crack a lot and lots of teeth trouble, just bad structure. And so I've like, oh my God, that's going to cost $1,000. Are you kidding? And then it takes me a whole year to save to solve one tooth problem.
Right.
And then so I really have a deep empathy with these poor women at AWAC where their mouths look so sore and so often infected and swollen, and depending what kind of drugs they've done, or even women who have had anorexia, I saw that too, that if you vomit a lot, you can have acids that ruin your teeth. So the pain that they're in constantly, and if you're on welfare or whatever it's called at different times, any kind of subsidy from the government, they will not pay for you to get your teeth fixed.
They pay to pull them.
Because they'll only pay to have them removed. But here's the interesting part that I was, in addition, like I kind of suspected that, but it got worse and uglier, that they would, if these women were in incredible pain and they went to see a dentist or a doctor where it was this subsidized thing where they could get their tooth removed, sometimes the doctor or dentist would not even offer them Tylenol 3 because they would be of this impression that it will just further or deepen their addiction. So it also made me think of the whole Christian idea of you should suffer for your sins.
Yeah.
You should be punished for your heathen behavior. And I was astonished by that. And then the whole thing, anytime I do go to the dentist, they always give me a prescription, you got your teeth cleaned. Here, I have a prescription for Tylenol 3.
Right.
I was always getting this prescription because I guess they look at me and they don't go addict, they don't go indigenous, they don't go user, right?
Totally.
And I get prescriptions, right?
Yeah.
So I was kind of shocked by that some dentist or doctor would be that much of a bastard to not even offer them the prescription. And
that's
very
really
shaming, very judgmental.
Yeah.
So of course, what many of our clients do is when they get into this constant cycle, and Gabor Maté talks about this and others, that I'm in pain, I'm in so much pain, my soul is ruined, my mouth is aching, my foot is infected, I don't have anything joyful to look forward to, so I think I'll get drunk or stoned, which then continues their troubles. You're embedded in a life of constant cycling. At one point in the day, your pain increases, whether it's your dental pain, your foot pain, your psychic pain, so you're keen to get drugs to manage the pain, which the longer you do that, the more you're going to have psychic pain, economic pain, mouth pain, right?
Right. But I think that that is even kind of a stretch. I think that often we see people who use drugs or alcohol extensively, and we assume that if they never did drugs, their life would be fine. Or if they stopped drugs, their life would be fine. Yeah. And it's actually, for some people, especially opiates, I think any drugs, opiates for people in pain, stimulants for people who deal with psychosis or are living on the street. Yeah. I think that those things actually make them more functioning than they would be. Yeah. It really depends on the person. And then to just assume that that someone is in the state they are simply because they're doing drugs. We can't always assume that.
Right.
It could be pain, mental health, poverty, lack of sleep.
Yeah, 50 kinds of trauma, and there's often that expression of self-medicating. So
Right,
that
exactly.
the soul, as Gabor Mate talks about, and he's kind of famous in this realm, and my understanding of him, and correct me if I'm wrong, I have his books, but I haven't memorized every sentence, but that he's kind of famous in that he makes the case that almost all of the people he has seen working downtown East Side area where there's a lot of trouble, almost all of the people he's seen have been sexually and or physically abused as children.
Yeah.
And so that impels them towards wanting to heal or function or have some hope or energy feeling inside themselves, so they turn to drugs. But then also once you're doing drugs, it can put you in a place where you either individually, you're more vulnerable to fall down a flight of stairs, or you're more vulnerable to fall asleep somewhere and maybe freeze off one of your fingers, or right. So you end up with more physical pains because of being, let's see, foggy brained for the moment.
Right.
I can't think of another word, foggy brain. And then also, the more you get into that lifestyle, the more you end up living in a dump where you may have mold, or you may have catch more colds or diseases because the place is really dumpy, and right. So that the further you get in, the more pain you have, which will guide you towards having more drugs or alcohol. So having said that, as someone I said in a previous video, I've been on antidepressants for more than 2 decades. Different kinds, right? So someone could say, I am addicted to my antidepressants and I always want more. I always like, when I have a life crisis, I'm like, maybe this is time to increase my dosage again. And the situation was, so a couple things I want to point out, that because you could say a middle class person now, I have a healthcare plan that pays for my addiction. I don't have to go do blowjobs with anybody. I don't have to steal stuff because I just go get my prescription filled, right? And it's a sanctioned drug, and it's a drug that I don't have to be embarrassed if I feel it's not working. I can say to my family doctor, I need to see the psychiatrist again because we need to look at my dosage. It takes 6 months to go see the psychiatrist. Right. I always mix up psychiatrist, psychologist.
The psychiatrist is the one that be prescribing the drugs.
Yeah. So then I see the psychiatrist for 5 minutes, and then they'll up my dosage. Right. And I'm always astonished. Okay, you went to school for 100 years, and I have to wait 6 months to see you so that we can spend 5 minutes of quality time together. And you raise my dosage. Versus what we were saying about the person who's struggling, and is drunk or stoned in an elevator, and then we take that person and throw them on the street, and then we might do that 40 times a year for 40 years. Right? They have an addiction, I have an addiction, and both are being treated completely differently. Totally. Right?
And there is like an expectation a lot for drug and alcohol dependency to be treated by having like a stronger character. You know what I mean? Like, for instance, recently my boyfriend went to the emergency room. He was dealing with active psychosis, and the psychiatrist told him that he should go to AA.
So it was inferring a completely useless suggestion. He would have thought of that on his own if it was a perfect thing.
Exactly,
right? And he would have done it on his own. He wouldn't be in the hospital, right? It's condescending when someone offers us a stupid solution like that, right?
Yeah, and that goes back to my point where we see the drug or alcohol use as like what is causing things, and like as social workers, we may deal someone with addiction, and we think, okay, our first priority is to get this person off drugs, get this person off alcohol. But what are their goals?
Yes.
And what is, and if they're using drugs or alcohol to like a constant, like chaotic pattern that they want to get out of, then what is driving that? And how can that be mediated? For my boyfriend, he has bipolar. He was extremely under-medicated, but no psychiatrist would up his medication until he was finally arrested and put in 3 Northeast. And if they just upped his medication instead of telling him to magically quit all substances, which he was doing to actually make his mania go down and dampen and being able to sleep,
Right.
then it would have prevented 2 months
So if
of
they would
absolute
have
hell.
listened to him,
Yes.
he is the expert on the pattern of his life.
Yeah.
I am the expert on the pattern of my life. I.e., I say to the doctor, I'm feeling more sad, I'm having suicidal ideation, I hate my boss, my workload is tripled at work, I'm being expected to perform all these incredible magic feats.
Right.
I'm full of rage, I can't sleep, I'm crying all the time. And he may say, oh, gore or whatever, right? Some quick, glib kind of solution, and put me on a waiting list to see a psychiatrist who will talk to me for 5 minutes. Well, why don't you just let me talk to you on the phone for 5 minutes right at that day? Why wait 6 months?
Right.
Right?
Yeah.
It doesn't serve my purposes, and the doctor doing that doesn't. Like, the only purposes that are solved are the professional organizations and their entitlement to be drug dealers. Right? The psychiatrist is in effect the dealer in that story.
Right, which is so ironic right now because there's such a backlash from doctors over the new safe supply guidelines saying that they don't want to be drug dealers.
You already are! Spoiler alert!
Yeah, exactly. Whereas we'll prescribe things like Nicorette gum or nicotine patches or naltrexone or methadone. And to me, it's part of the same continuum. And if people want to access, people want to get off street drugs and access prescription drugs instead, we should be applauding that and like listening to what people want. And I feel that there's a stereotype about anyone who has sort of a pattern of addictive substance use that we can't trust anything they say.
Right. So when a woman is saying, I'm in a lot of pain because you just pulled out 5 of my teeth, which were rotten and infected and swollen.
Sai is such a drug seeker.
Yes, right.
Are you looking for something to mediate your pain? Well, that's seeking drugs, and you have this history, so no.
Right, right. And, it's obscene.
Yeah,
and when these women
really
at
obscene.
AWAC were telling me these stories, I thought it was obscene. They were trapped in a situation where to actually fix their teeth, they would have to save maybe $2,000-$3,000 to get false teeth and stuff like that. If they were to save, I think it was $800, they would have been cut off their welfare. And they can't even save $800 when you're on welfare. So let's say their grandmother suddenly died and gave them $5,000 and they were going to spend the $5,000 on their teeth. At that time, my understanding was they would be told, okay, well, we're cutting you off welfare for 5 months.
Yeah.
So they were completely stuck in a ridiculous cycle of stupidness between the doctor, the dentist, the social worker, all the situations, right? Where we would wish them to be in our dream world, because that's what we're dreaming here, social work with families, social work with victims of abuse. In our dream world, we would say, 1, you should be able to see a dentist without it costing thousands and thousands of dollars. To fix one tooth, when they say $1,500 to fix one tooth, and you're in there for your root canal, you know, you're there for, maybe you're there for 2 hours waiting around, but they actually do stuff for 15 minutes.
Right, yeah.
Why does that cost that much money?
Yeah. I know, and it's as if like your teeth aren't just as important as, like, if you broke the bones in your hand.
Exactly.
They're not going to charge you for every bone that they're fixing.
Precisely. We have access to some healthcare that's affordable or free in Canada. Expanding that to have it be dental care and expanding it to be pharmacare would cost less for a whole society. This is a pattern we can see.
Plus eyes and feet.
Right, eyes and feet. You get your glasses for free or almost for free, or your dentist for free or almost for free. No matter who you are, no matter what. We've been dreaming, what would that world look like? And this, in the way that I'm able to get my antidepressants for, I only pay 20% of the cost, but we also know even that the pharmaceutical company might, if the prescription is $100, the pharmaceutical company might be making $60 just pure profit, right? The pharmacist charges $10 to make my prescription.
Yeah.
What do they call
Dispensing fee.
Dispensing fee. So, right? Like out of $100 for these pills, in a way, they're as bad as the person on the street saying, "Here, some amphetamines, and I'm going to charge you $100 for them because I want to make a markup of $80."
Right.
Right? And in the sense that the ordinary person, I am addicted to my antidepressants. I'm addicted to root canals. I just randomly go get root canals
All the time.
Yeah.
all the time, right?
Yeah.
And so what I'm wishing is that we reflect on this, because it's also the other pattern here that we want to talk about with social work with victims of abuse and family counseling is when one person has a whole bunch of troubles and pain and anguish, we want to reflect on that has meaning or consequence, short-term or long-term, for their mom, their sister, their boyfriend, their colleagues, their community. All of us are in this together, said differently. And do you want to talk about that a little bit, of what does it mean if one of your family members, someone you love, is in this struggle, right? Said differently, my family, if they weren't in jail, my family, if I had people who loved me in my family network, my care network, they too benefit from me being on antidepressants.
Yeah.
The hotel that has the elevator person, they benefit when people don't end up passed out in their elevators. Right? Could you talk about that? How it, because often it's just, oh, there's this one person, and if we just punish them and shame them and give them some pills and put them in a treatment program, joy to the world. But it's bigger than that one person, isn't it? It's a whole ripple.
Right, and I think that a lot of that ripple is sort of created by the shame and criminalization that we put around drug use. Or we're putting the blame on the drug use rather than looking at sort of like patterns of trauma. Like, is the problem that they're using substances, or is the problem that they're abusing or neglecting people? Well, those are the real problems, and they're not always like tied up with using substances, and those are the things that we should be addressing. So it's like, how can you, even while sort of like mediating your pain, can you also not subject other people to abuse? How can you still be a good family member or parent? And just like focusing on those aspects, because I think when we keep the focus on, oh, you're using drugs and that's a cycle of chaos and everything around you is chaotic, we're kind of creating that chaos. And I don't think it's like, and it changes for different people. I think that some people can use drugs actually really responsibly, and if it wasn't for the fact that it could make you lose your job, lose your home, go to jail, et cetera, et cetera, et cetera.
Secondary traumas or secondary disadvantages that just spiral out.
Yeah.
That if we could get rid of all of that kerfuffle and chaos and say, okay, like me, I can get my antidepressants, I'm not stigmatized at work, I function, I pay my hydro bill, stuff, right?
Yeah, exactly.
Right? So if more of the people who are now ending up completely isolated, abandoned, and exiled from society, and often exiled from their family, or their family, let's say their kids are taken away from them because they have the addiction, if we managed all of this in a different way, if they could go and get methadone or whatever their
Prescription heroin.
So talk about that. So let's take the guy in the elevator story or something like that. If he could get what he needed to function and cope, talk about that. What would we need to accomplish in the world to make that happen?
Well, I don't know that guy that much, so I don't know what he needs to cope. But I know that one really underprescribed drug now is naltrexone. Naltrexone. This is actually what this book is about.
Okay.
And I've only just recently heard about it too. And
okay.
I think the fact that it's so underprescribed, I read an article that saw it being suggested maybe 3% of times when people were admitted to the hospital for alcohol-related reasons. because doctors still have this idea that people should just suck it up and quit drinking. So naltrexone is a drug that targets how alcohol and opiates and other sort of like addictive things, how it accesses like the dopamine in your brain.
Yes.
So it becomes less rewarding.
Yes.
So then you crave it. You don't crave it as much, or you don't crave it at all. And when you take naltrexone before you drink, you don't want to keep drinking. It eliminates the binge drinking. It doesn't work for everyone, but it does work for a lot of people.
Okay. So I remember watching a documentary about this. A doctor who had become, and he was from Vancouver, if I remember correctly, who had become addicted to different things, and he found this medication, let's say, let's say a substitute, right? And he was, that might have even been one of the reasons I wanted that book, was that he was saying this could be a revolutionary resource of support for some people to help them not use drugs or alcohol, but it could also be some, so for a year or 2 years take this and then wean yourself off or something, correct? So,
or you only sort of need to take it, sometimes people just take it before they drink.
Okay.
Or when you feel that you will be tempted or surrounded by alcohol.
So high risk moments in your own life, right? Okay. And so then it's more centered in the person themselves.
Yeah.
Right, so I have bottles over there. If you want some when you leave, I got Tylenol 3. I got lots of it, but I don't actually like it.
I don't like it either.
It's
It makes
just
my
weird.
chest hurt. Yeah.
It doesn't necessarily even help the pain in my mouth from the toothache fix. It's just like what? It doesn't do much for me. But I have the prescriptions. But it's up to me to make my decision. The doctor says, here's the strengths, the weaknesses, the pros, the cons. Here's some Tylenol 3. Go by that. And if your tooth is still hurting in the morning, you could take one.
Yeah.
But it's centered in me, not waiting 6 months to see a psychiatrist for 5 minutes.
Right.
Right?
And I think that a lot of treatments, I mean, I think there's a benefit for people going to treatment center if that's what they want to do, but a lot of people don't want to give up their entire life in order to receive any help, and they want to stay with their systems of support or the things in their life. You know, we have this stereotype that people who use drugs are completely useless. I see the stereotype coming up a lot lately in new comments, and there's a lot of news stories about Safe Supply in Vancouver right now. An activist group held a rally for Safe Supply, and then they were actually giving out opium and cocaine.
Okay.
And then there was a huge backlash. Be like, oh, our taxpayer dollars. Well, it wasn't your taxpayer dollars anyways, but saying like, oh, these people are such a drain on the system, and like, you know, a lot of people do have jobs, or they like contribute to their communities, their like local economies. You know, they're all part of like a
and we also know there's
interconnected
people
system.
like Walmart who expropriates the worth of their employees, and they get $1 million in tax breaks. And we don't go, well, look at Walmart. It's just a welfare loser person.
Right?
They're addicted to profits, and we just have to punish them, right?
We should punish them.
That's like, yay, Trump.
Yeah,
yay,
they're creating
Walmart.
jobs, right?
So if in a different world, if we dreamt a different world, we would, one, every person who had a struggle like that, a wound in their soul, let's say, from being abused as a kid, or some trauma or some deep grief or whatever, or born with struggles, just born with, you know, some people still say, and I don't know, my father has clinical depression at one point, and I don't know because I don't have a lot of contact with him, and then my biological son, clinical depression, I have clinical depression. I can look back at my mother's life and think she had clinical depression. So some people say depression is just you make that up, you know, you got a bad attitude, and you just pull up your bootstraps and you'll be fine. But in my own body, I know when my clock winds down. People imagine depression is often, you know, you just sit around and cry all day. Well, I don't even have the energy to cry. I just want to go under the bed and just stay there and stop breathing. Like if I could will myself to stop breathing, I would be really happy. Like in a way, right? My point being, every person who has pain, it's nuanced, and we need to be discerning and very specific and unique. We also need for each of them to be able to say, this drug works well for me,
Yeah.
or it doesn't, and it works with this level or on this day or in this mix, because only we can speak to our own body,
Right.
right? That's why I always laugh of, why do I need to go see a psychiatrist? I wait 6 months who sees me for 5 minutes. They don't ask me anything about my body or anything. I'm a vegetarian. I'm a vegan. I have insomnia. My feet are sore. Like, they don't ask about my body, right?
Right.
Actually, the one I've seen here asks things, although the file is this thick, they say, so do you work? That's the first question. Do you work?
Do you have a job? Yeah.
So,
And I think that, and we have to sort of like reconsider like what we consider to be recovery. And for when we look at someone who we see as having a drug problem, often our goal for them is to break out of addiction and have no substances, for instance. But like, as you point out, like a lot of people do consume a lot of substances and medication, and it fills a gap in their brain, and it's just not actually realistic to like cut all those things out. So if someone wants to switch to a safer pharmaceutical alternative to what they're doing on the streets, especially right now with like insane numbers of overdose deaths, higher than ever, fentanyl and everything, fentanyl and cocaine, fentanyl and meth, fentanyl and crack. The group that was handing out free drugs at that rally, they wanted to hand out free heroin, and they couldn't find any heroin without fentanyl in it.
we've had in the recent past, just for the viewers who may not watch the news every day, I think it's 170 people have died this year.
Just May.
Oh, in May, 170 people in May
Yeah.
have died from an overdose, a drug problem like this, and more people have died from C19. Some people are making a contrast of, we make all of this worry about C19, COVID-19, to say, we want to help everybody be safe. We want everybody to be in this together. We all need to protect each other and do the right thing.
We have to rethink how we look at, how we interact, how our jobs are, how childcare is. Well, we need to rethink how we're looking at addictions and what we're taking away from people who are at risk of dying.
Yeah.
Because even though the provincial government released guidelines for doctors to prescribe pharmaceutical drugs for people at risk of withdrawal, and doctors aren't prescribing them. Because they have this idea that they're fueling that addiction, that it's the addiction itself that is like creating like evil people. But it's, if you're giving them a prescription of Ritalin so they're not doing meth every day, they're saving money, they're not at risk of death, they're not stuck in that cycle of looking for drugs, so they have time for other things.
Yeah, and when they buy their drugs, I did a lot of amphetamines earlier in life. I love amphetamines. I still miss them. Oh, where have my amphetamines gone? I love them because they made me feel really alert, and I can look back and think, when I was having depression, for me, in my body, amphetamines were the opposite of depression.
Yeah.
They make me feel like, okay, I can do stuff. I could paint the kitchen. I could paint everybody's kitchen on the whole street. Right?
Yeah.
And at that time, in that community, I always kind of knew that my pills were clean because doctors, interestingly, this is a historical thing, doctors would commonly prescribe to full-figured women these diet pills.
Right.
They were called yellow jackets or black beauties at the time. And so these women would go and ask doctors to give them this. Doctors would give it, no problem.
Yeah.
And then they'd sell them to me and others. Right?
Right.
So it's like, oh, look, thank you, doctor person.
Yeah.
So I tell that little story for a couple reasons. One, the doctors were prepared to help full-figured women.
Yeah.
Right? Which is completely an aesthetic thing.
Well, skinniness is so important.
Yes, exactly.
Any means necessary, of course.
Exactly.
Right?
Exactly. and then I was fortunate to be able to get drugs that I knew were clean. Right? And that eventually I stopped doing those drugs without being in a treatment program or anything. I just kind of weaned myself off because life wasn't demanding that I work full time and go to school full time and do full time other things full time, right? And then also I got antidepressants, so that helped me. And so I found my way of grace through it all, and here I am, right? That I'm okay. I have a job and I have a life and everything. But had I had to buy amphetamines that may have been dirty, like I could have ended up with a heart attack or really sick or got hepatitis or fentanyl overdose. So our future world, if we had our way, would be that the client themselves can identify what they need and what might help.
Yeah.
That we offer them clean, you know what I mean by clean, uncontaminated with everything from, because we've talked a lot about fentanyl, but it could be contaminated with anything when you buy drugs from anybody in the corner. It could be with rat poison, or it could be gyprock, like from the wall, white powder, right? You know what I mean? It could be anything.
And the sad thing about living in the north is that we don't offer drug checking services that will tell us all
what's in there.
Yeah, and every other health authority, they have machines that tell you everything that's in the drug.
Right, so we would wish that people would be able to have a consultant, let's say, an advisor or a consultant. So rather than see a psychiatrist for 5 minutes, that you could go into, if you had a safe, clean place where you could be fully self-disclosing and not get judged or punished or arrested, and say, this is what I feel I need, something to manage the pain with my teeth, or something to manage the pain of when I try to go off these drugs, my bones ache.
Yeah.
Or when I go off, I feel suicidal, or, right? Going off amphetamines too fast, if you've been taking a lot of them, can make you feel suicidal if you have depression underneath it. So that each person could customize their dialogue, their information in a non-judgmental way and get resources like methadone or
Suboxone, but even some people are being prescribed like hydromorphone if they have an opiate addiction, or Ritalin or Dexedrine if they have a stimulant addiction.
Okay. So that would save lives. It would, in the long term, and here's another pattern, this will cost lots less money.
Yeah.
Right? Because a portion of those people will be able to maintain their full-time work or their school or whatever the other things are, that when they get pulled into all the drama and chaos of the street, let's say, you have to go buy this drug from this guy or this pamper, some person that does not have your growth and personal self-esteem and long-term well-being and ethical guidelines, like a social worker, we
someone that wants the best for you.
Right, yeah. Right. When I go buy street drugs, I don't know if he wants the best for me. I don't think he does.
At the end of the day, he wants money.
He wants money for his drugs.
But I think that it's like, but also I think it's like kind of dangerous to really like pathologize the drug dealer, because often it is like, let's say a woman, it could be a woman my age, I live in a building, if I buy lots of drugs, it's like cheaper for me, I care about the people in my building, I don't want them to go through withdrawal, I feel like I have a good source.
Yeah.
It's not always like...
So there's a weird trust. Like I got lucky, like I said, I do full-figure women, I trusted them and they sold me stuff. And they were making money to subsidize their welfare.
Yeah.
Right? So it was a good. A win-win, pharmaceutical company, everybody. Did good. So, if you could talk for a minute about the whole wraparound idea. There's this, people on the outside, my knees get so engaged. Why show is wiggling? There's been a whole thing about wraparound services, so that we help a person find, there's been in the past a belief of, if we punish and shame this addict or this person with alcoholism struggles, if we punish and shame them, at some point they'll have an epiphany, they'll pray to God, they'll pull up their bootstraps, they'll say amen, they'll go to AA, they'll stop drinking or doing drugs, and then they'll have a happy life.
Yeah.
My belief and what I've been witnessing is that is a very rare story. It could happen, but it's a rare story in general. And in the past it was, if they do all that stuff, then we'll help them find an apartment and we'll help them find a job and help. But first, that. And some people with this wraparound model have been saying, whatever they're drinking or whatever drugs they're doing, whatever, first, let's help them find a clean, safe little bachelor apartment place.
Right.
Where they could get regularized, where they can have good nutrition, where they can build their self-esteem, where they can renew their hope. Because hope is our species is addicted to hope.
Right.
If you have no hope, it doesn't matter, right? Like if you have no hope for your future, why not do fentanyl? Like it's not, people have come to a place of complete defeat and surrender to their addiction sometimes. So if they have the hope of, okay, you've got this nice little apartment now and someone's going to come on Tuesday and they'll help you get your hair done, or, you know, the hope, the daily, weekly kind of hope.
Right.
Do you want
Just
to talk
even
about
like,
that?
yeah. So that's basically what you're describing as like the housing first model,
Housing
which I
first
totally
model.
agree with. I don't think that people should be forced out of their housing because they're still using substances, and I think it's extremely hard for people to quit substances while they don't have homes and they're on the street. And Housing First also saves a lot of lives. Staff are Narcan trained. People are allowed to use in places where they can be supervised. I think that's really important. And even just like the safety and the quietness of your own room, I think is like really important. That's what I think of.
Yeah. Especially the safety. So if we're reflecting on social work with victims of abuse or family, somebody, a young woman who's been sexually abused, and that's part of why she's ended up reaching for drugs or alcohol to kind of soothe her damaged soul. The more she drinks or does drugs, the more likely she is to be physically or sexually abused again and again. And if she does turn to survival sex trade work, that is just constant abuse.
Or she could be doing meth all the time, so she never has to sleep. If she doesn't have a home to sleep in.
Right, exactly. Or people who know they're going to have to sleep behind a bench somewhere, they may drink more so that they don't feel the cold as much, right? So by saying, here's your safe little bachelor apartment, even if it's as big as this, but they have their private bathroom, their little kitchenette. I've seen these little spots in Vancouver where it's just tiny, but everything is condensed and effective. So you put them in there, you can start to hope. You can get them addicted on some kind of hope of maybe next month my life could be better. So I'm going to try harder to figure out day to day how to be better, right?
Right, exactly. And it's like, but we can't have these like expectations of like, oh, you have a home now. Like, what are you doing to improve your life? Because what is your idea of an improved life or a life worth living? And are you projecting onto these people?
Good
and
point.
also,
Good point.
It's like you have to unravel like sometimes like a whole life of patterns.
Yeah. Or generations of
or
patterns,
they
too.
actually just have like a deeply ingrained mental illness that can never fully be, I don't want to say fixed, but do you know what I mean? Like
managed in a wholesome way. They may always have a vulnerability to depression or to a psychotic episode or to a rageful explosion, right?
Exactly.
So we're
and
looking
there
at harm
needs to be
reduction.
housing. There needs to be like a continuum of housing. There needs to be housing that is patient with those types of behaviors, like acknowledging that that behavior can be like embedded in like mental health, like or mental illness, like acting out like what's going on in their brain, and that those types of things should always be punished. Of course, like we have to make sure that people aren't harming their neighbors, but just sort of like a little bit more patience with, acting out or explosions.
We did a video, and I don't remember which one it was, but we talked about there's this idea out there that there's some professions or some people who are evidence-based, they're factual. The bankers, they know what they're talking about. They looked at the charts on the economy, gross national product. They're factual. They're real. That's research-based. And then the kind of stuff we've been talking about is seen as like, oh, the crazy social workers, the hippies, the full of love and all, broken heart and all that. And that somehow we are not acting on evidence, knowledge of patterns, knowledge of best practice, knowledge of what actually works.
Well, yeah, which is so wild because actually, like, prescription heroin is amazing. changes people's lives.
Yeah.
And yet there's such like a dogma or like an ideological opposition to giving those things because they're addicts and we can't give them what they want.
And one of the things that I think is useful is to reflect on the history. And if we take, for example, cannabis, I've seen some old documentaries of cannabis will make your children crazy. And
Of course, right.
And now we realize, meh, we legalized it and all kinds of people can go buy it. And all kinds of people could go buy it and do it once and kind of go, yeah, right?
Exactly. And of course, and like working in mental health, and that has been like a struggle for me because I've actually been a pot smoker my whole life since I was 14, filled some gaps. I have a 4.0 GPA. Probably have never seen me not stoned. It's fine.
I do on antidepressants every time you saw me too. Look at that. I'm addicted. You're addicted. Why?
So there's this new group, the Drug Users Liberation Front in Vancouver, and they're pushing towards decriminalization of all drugs, safe supply, and their point is, so we legalized marijuana. Now there's white men in suits walking around smoking joints. Did they just start smoking pot when it became legalized? No. Absolutely not. And we know, you know, there are like lots of rich people doing so much cocaine, so much heroin, and it's not necessarily, and they have productive lives and they make a lot of money, you know, they're at their jobs, they could have like happy family lives, we don't know.
Portugal, am I correct in that? Did they legalize all of these things? They just said do what you want, kind of.
Yeah, it's a little bit more complicated.
Do you want to share what, because in previous videos I said, oh, this idea happened in France and it went okay, right?
Right.
So are there countries right now in the world where best practice, as we might imagine it, is being lived?
Yeah, I want to say in Rotterdam.
Rotterdam.
Where's that, in Sweden?
Norway, maybe.
I just read a study out of Rotterdam and they're saying that prescription heroin has like a 50% recovery rate if we measure recovery as not doing street drugs, having like a healthy, productive life, but basically just no involvement in doing street drugs anymore. And they're just seeing that as being recovered. And I've seen that in my own life.
And
I've seen clients.
Deaths from bad drugs.
Yeah, clients go from coworkers from prescription heroin in a matter of months. I know it's not always that quick, but we just provide the safe drugs that people are trapped in this dangerous cycle of obtaining, and it's dangerous to take, they don't know who their dealer is.
So decriminalization and guidance about what's in your drugs and how many you might wish to take, and somebody to dialogue with who would be safe, non-judgmental, who would not, you could see them just by walking in, you don't have to wait 6 months, you don't have to go through the doctor, to the psychiatrist, to the pharmacist, that just right there, right now, one person or one agency could help, and you could move into a better place very quickly.
Yes.
Not 6 months or 6 years. So having said all that, and I think we mentioned earlier that there's people who go to a treatment program, another treatment program, an additional treatment program, 6 months in a treatment program, and nothing really changes for them. So what are your thoughts on that whole dimension of those kind of things that the mainstream thinks of? There's treatment programs, like retreat programs. I've been a bit, I'll tell you, I'll confess one of my guilty pleasures. Not guilty curiosities, not pleasure. I like watching the intervention shows, which are on, there's one channel where it used to be almost all day there'd be intervention. And I would watch them and I would, with my social worky kind of mind, I'd be thinking, I wonder if that's really true, or if that really works, or how would that have played out in Prince George, or what would have happened if the mother wouldn't have done this, or, because I see them as kind of like case studies, let's say, these intervention shows. And so what are your thoughts on the treatment programs, on AA, on Narcotics Anonymous, the 12-step programs? There's a lot of stuff out there that is often kind of thought of as gold standard. And my witnessing so far has been that for a lot of people none of that works.
Yeah, and I think that we need to have a variety in and what options people have, what they want to access. I know that NA and AA work for some people. According to the research, the numbers are quite low, but I don't want to diminish the experience of people I know who that has really worked for. And I think that for some people, they want complete abstinence, and some people, they need sort of more of a maintenance.
Harm reduction.
Harm reduction, or like a safer supply of drugs.
Well, my curiosity too is some of these programs, this is one of the patterns. Our funders often wish, whether that's this program or that program, often the funders, what are they looking for? They're often politicians, like the real gatekeepers, the decision makers. They're politicians who are looking for something that can be a one-liner on the 6 o'clock news just before election time. Either to, we're going to punish all these bad people, vote for me, or I'm going to create this program, vote for me. Right? So it's often sort of shallow, and it's also often a sort of a McDonald's version of the universe, versus humans are not a burger.
Right.
Write that down. It might be on an exam. Humans are not a burger. Right?
Right.
That every single human, even with other kinds of completely different health issues, right? That it'll say, 80% of people, this happens. But there's those other 20% where we don't know, other stuff happens, whatever it is.
Right, and with AA and NA, it's more like 80% what does happen, and 20% it does work for.
Right.
And I think that the reliance, for instance, if you go to if you're staying in a halfway house, you basically are forced to go to AA and NA, like quite often. Quite often people are forced to go to that. And I think on one hand, that is like another example of our society, like creating, burdening the volunteer sector with our real problems.
Right.
Because
and
those
things, are volunteers.
Those are
aren't necessarily
volunteers.
specialists or anybody that's super brilliant about that particular person.
Yeah.
Okay.
And I know that for my friends who are in A and NA, they hate it when those people come. The people who are forced to come. It diminishes their experience.
Yeah.
They're there, they have a formed group, they're like quite vulnerable, they want to have new people who are like really committed to what they're doing. When there's like a group of guys straight out of jail and they're forced to be there, like that doesn't help them.
Yeah.
It makes the experience like weirder for them.
But it's still that Christian, let's say, element of punishment or shame. So you've had the struggle, you've been in jail, you're coming out of jail, you're going to go to these AA meetings or 12-step programs or whatever. You're going to do that Tuesday and Thursday. We don't want to talk to you about anything. Just do it. Just do it. And that is bad for the others in the group. It might be bad for the person.
Yeah.
Right? But the funders who are looking for that 6 o'clock news two-liner.
Yeah.
From now on, all people
mandated treatment.
Mandate, bootstrap.
Yeah.
And so I just keep coming back to that kind of idea, because one of the big patterns with all these issues is that the world has this idea that it's all evidence-based. Like these programs wouldn't, it has to be 100% because otherwise why would people support it so much, right?
Right.
Well, so there are things in the world where, that's evidence-based. Research was done on that. There was documentation, right?
Right.
Well, maybe not.
Yeah.
Maybe not. Maybe the funders are super keen on it because this doesn't cost any money. These are volunteer-run groups.
Yeah.
And some of the other programs where we're wishing to make it very unique to each person, it might up front cost a little bit more money than sending them to jail for 20 years or putting them in the hospital, the guy who passes out in the mall or something like that. And he gets put to hospital, and then 24 hours he comes out, and 3 days later he's in the jail drunk tank. And then he's out, and he does that 40 times a year. The same 10 people you were saying, that there's some of those drunk tanks where the same 10 people 10 times a year.
Yeah.
So that's not working.
Right. But then I guess it's like, why are we saying like what works? You know what I mean? Like, what are we measuring as what works? Like, no, like, obviously I don't think that a police-run drunk tank is the best thing. But it's like, the goal is to put that person out of harm's way.
Your own little apartment.
But I mean, like, let's say we have like a sobering center. If people keep going back, are we going to be like, that's not working?
Okay.
When we can be like, well, each time someone goes to that, it's a success. They lived through the night.
Okay.
They didn't do anything.
Yeah. That we would wish that each person, wherever they are in their journey, I guess where I'm with you that through the life cycle and through whatever the person's unique trajectory and story and trauma, so we want to customize it, we want to make it unique, we want them to be in charge of it and in control of it. But I guess part of my mind is speaking to the funders who'll say, we already have this drunk tank program. Right. We already have AA. We have NA. We have churches. We have all those work programs where we give a guy a shovel and he has to go dig some holes. It's a good world. Why do we need more?
I know, and I wish, because I've seen a lot of articles from the chief medical officers of Northern Health saying, oh, we have all these really great harm reduction programs. And I want to shake my computer and be like, what? What harm what are you talking about? And like the article will be like, well, you know, we have this safe consumption site in Prince George. Like, you have one safe consumption site with 2 chairs. It's open from 1 to 6. Like, well, I'm not sure like how they justify that or like
so
not expanding those services. Like, well, you know, we do have NA and AA in the community, so what else do we need to do?
Right. That's what I'm always wondering about, is that we have to be careful what we ask for, and when they say we already have programs for that, we have to reflect on, do you really, or was that something that you created during the last election so that you could announce it on the news and now we're done? Right?
And what exists, is it adequate?
Is it adequate to serve the population in a substantive, rich, complex way? We know with many women's services, they're like, well, we'll give you $3,000 to design a pamphlet. We have pamphlets for... Well, the Women's Center might have 49 pamphlets, but Sarah, our Women's Center coordinator, is only paid for 10 hours a week, and she's paid poorly. Right? So I don't care if you got 10,000 pamphlets. You need unique human engagement based on trust, empathy, wisdom, and the pacing that's going to suit for each person, and so on. Right?
Yeah.
So I know my video team here are starting to get impatient with me, that we prefer the shorter videos, but this is such a big topic.
No, I'm sad. I can't pet Busy.
I'm still over the cat. It all comes back to cats.
It always does.
So what... If there were one, two, three things that, let's say a student who's finishing their 3rd year of social work right now and they're going to go into their 3rd year practicum in social work and they're taking a course on family counseling or they're taking social work with victims of abuse, what would be some things that you would want them to really remember when they're, if they're working, let's say, with the spouse of someone who has an addiction, or they're a child, you're working with a dad whose son has an addiction, or you're working with the clients that Gabor Mate refers a lot to, of people who are already on the street. One other thing I got to add this. A lot of issues, we have to remember the quieter ones, we don't see them. So we've taken the story of, let's say if you're a settler person and you go to Save On every day and buy groceries, and that's sort of your life. You've got your nice job and you've got your nice little house and you go to Save On, and every day you see 1 or 2 Indigenous men asking for money at Save On. Right? You have no other Indigenous people in your life that you know of, and then you saw 2 guys asking for money and you go, oh, all Indigenous people beg for money. Right?
Right.
So, but that's totally not true.
Yeah.
There's meanwhile 9,000 Indigenous people living their life, doing their thing, fixing their truck, making smoothies. But you didn't see them because that's not your world.
Right.
You're not intersecting with the world. And there's many people who think they don't know anybody who has an addiction.
Right.
They think, oh, I've never met anybody with any of these issues. I told them the story of, I met a guy who's my husband's friend, who's in his 40s, has a master's degree, smart guy, and he's living on Spruce Street here, just down the street. And at one point he said, all this stuff, women and feminists talking about rape and incest and sexual abuse, I've never met anybody who's gone through those things.
Oh my God.
Okay? And Ken and I both laughed because well, one, you know me.
Yeah.
And two, you live in Spruce Street.
Yeah.
And three, we know 1 in 3 girls
Yeah.
and 1 in 6 boys by the age of 18 will have been sexually abused. So trust me, you've met people. They just haven't told you because you're kind of an asshole.
Yeah.
Right? So what those people who haven't met anyone or they think they've never met anyone with an addiction issue, what would you want them to know?
I want them to consider how they're sort of scapegoating the substance use for other problems in people's lives. Okay. One thing that comes to mind is when they take kids on tours at the downtown east side to try to influence them to not do drugs. Yeah. And they see people flailing on the street. Could be a little bit of drugs, could be actually they have complex schizophrenia. Yeah. They have a lot of trauma. There used to be no health clinics in that neighborhood. People have been deprived of health care for decades. Some of these people live through residential schools. They live through the 60s scoop. I know women in that neighborhood who lived through one of those things and then also escaped Robert Pickton. Or they have dealt with their friends being killed by serial killers, all their friends dying through one of the overdose crises. There's one in the 90s and there's one happening now. So it can really, those things can really trigger a lot of like psychosis, erratic behavior. It's funny because I feel like it's like against our principles of social work, like, well, we have to fix the root cause. But the root cause is not always the addiction. What is that person coming to you?
Right? Displaying.
Exactly. So we need to, like, if they're genuinely asking for like addiction management, they want help into treatment, of course, let's do that. But then it's like, what are the problems that are happening? Is their life at risk? Are they at risk of overdose? Are they, like, help them with the problems that they actually want help with?
Yes. So a core social work value of you need consent from the client.
Yeah.
Get go.
Yeah.
I'm not going to put all this stuff on you. You've asked me for warm socks. It's 20 below. You're in your wheelchair. You're out there. You want warm socks. And I
give them warm socks.
Give them warm socks. And I say, is there anything else I can help you with? Oh, I'd like a hot coffee. Okay, a hot coffee, right? Versus, I'm gonna get you in an AA and your family in NA, and we're gonna put you in a treatment program and all this stuff. And the person's like, look, your socks aren't that fucking awesome, right? Then I'm gonna put up with all this stuff just to get socks.
Right? Exactly. And then I lost my train of thought. What else was I going to say?
But then each person, you have to have consent, and they have to ask you. They ask, I want help with socks, or I want help with treatment. As core social work value is, we respond to what clients ask of us and what they consent to accept from us. Not for us to just put this stuff on you or in you. That's invasion.
Right. And then we also have to acknowledge that we live in a system where drug users, and especially people with concurrent disorders, they're facing barriers all the time. People are kicked out of their housing for failing a drug screening. They're actually trying to go to the psychiatrist and get help, and they're not getting help. They want to go to a treatment center, but because they have a mental health diagnosis, they can't go. Our society creates untreatable people, and we can't see that as a symptom of them. We can't see these people as untreatable because they're not able to access treatment.
Yeah, exactly.
And just be acknowledge like all the structural barriers that people face.
Yeah, and come each day. If you're a social worker working with these issues, come each day with a clean and fresh mind, and not projecting stigma or shame or Christian ideology or capitalist ideology. All you need is a job. If you got a job, your life would be perfect.
I know, that's another thing. And this sort of like works in with the subject of like drug users and addiction. I feel that often the only time people ever talk about exploitation is when they talk about sex work. Yet we're saying, oh, you have a drug addiction, go work at Tim Hortons.
It's awful.
Yeah, like, they're like taking away your breaks, you're like making minimum wage. If they have the training wage still, you're making that. Like,
What do we mean by abuse? Oh, if
Or
it's capitalist and
exploitation.
Protestant ethic
Yeah,
and
I just like we're like
patriarchal.
forcing
Yeah.
people, like, oh, your life will be fixed if you just get a job. But we know we've all worked those shitty ass jobs, and
Nobody wants them.
they
Yeah.
destroy your brain, and they
Yeah.
can be really abusive.
Yeah. So are there any other things you want to add, Carlene? Is there anything we missed that we want to make sure we've covered for this particular video?
Not in particular. I feel like you've covered pretty much all of it.
If she's going to end up with a master's degree in social work.
Oh, wait,
from
I just
all
want to
these
tell one
videos.
more anecdote.
Oh,
because
yes,
I did it.
please, yes,
So
yes.
at my practicum, I shared an office with a nurse who I did really love, and she taught me a lot of things. But I didn't have a lot to do one week, so I was reading this book, and I was like, "Oh, have you read it?" She's like, "Oh yes, I love Mate." And then the very next day, she's like, "Oh, like I had this client, and we were meeting with a housing worker at AWAC." And, you know, he comes completely stoned. Can you believe that? Why would he do that? Maybe he needed to get stoned to leave the house. Maybe he has trauma dealing with, like, two professional women. Maybe he can't... Yeah, he has so much anxiety that that's what he needed to do, to step
Maybe
outside.
he needs 6 root canals
Maybe
and
he
his pain
needs
is
6
so frigging intense.
Exactly.
He took this substance so that he could cope to get out of bed and get here and see you.
Yeah.
Yeah.
So I think it's like that's another aspect of working with people with addictions is just patience.
Yeah. I am so glad that you got to talk to us today. I'm very grateful because I know you live this, work this, right? Yeah, I think many of these kinds of books, I can read 10 books. And we know that there's been 1,000 books that, for example, didn't disclose that the Catholic Church was sexually abusing boys and that the priests were just being moved around, right?
Right.
That book is still being written,
Right.
right? We know that there's all kinds of books that have been written about women and our bodies, and they were often written by men and people who had no feminist analysis. So I'm always keen, the people who right now are real in the world frontline working on issues, you're the good stuff. That's what we want for
And I
these
guess I never
videos.
introduced myself.
Oh
Should I
yes,
do it now?
introduce yourself. Yeah.
So
Hi.
I'm Jules. I'm a Master's of Social Work student. I've been working in the mental health addictions field for over 5 years. I've worked on a research project looking at increasing access to methadone for people who are pregnant in Nova Scotia. I've worked as a mental health worker for a pharmacy, doing home visits and witnessing, and I've worked in a harm reduction building for women and children. And then most recently, and actually my most educational moment, was having a partner that I lived with who had a major cocaine relapse during COVID, and experiencing firsthand the barriers that people face, no matter how hard they actually want to get clean.
Yeah, well, I'm grateful for the knowledge, and I'm guessing my future students will be grateful for the knowledge, and thank you very much. Super cool.
Thanks.
Yay. So that'll be on YouTube in a couple days.